Okay, this is Chapter 13, Respiratory Disorders, and I just want to say that this is probably going to be the most boring chapter that you've ever had to sit and listen to. When I went through this, it seems like the PowerPoint that I put together kind of goes through everything I'm going to say, so it's going to seem like I'm reading off the PowerPoint because I just made the PowerPoint very complete. So let's just get started. And the first thing we're going to talk about is diagnostic tests. Radiography is helpful in evaluating tumors or infections such as pneumonia or tuberculosis. Bronchoscopy is used in performing a biopsy or in checking for the site of a lesion or bleeding. Culture and sensitivity. You can test exudates from the upper respiratory tract or sputum specimen to ID particular pathogens that are causing an infection. Manifestations of respiratory disease, sneezing from irritation to mucous membranes, coughing can be tiresome to the patient when it is severe. Cough suppressants that are used, codeine containing or dextromethorphan, very commonly used cough suppressant. Removal of fluid from the lungs, expectorant, or a humidifier. Sputum or mucoid discharge from respiratory tract may have significant characteristics depending upon the problem. So sometimes you can look at the actual sputum and tell from the color what's going on. Characteristics of sputum. Normally, it's a very thin secretion, clear and colorless or cream color, not usually an odor per se. If it's yellowish green, cloudy, thick mucus, often an indication of a bacterial infection. Dark or rust-colored sputum is usually a sign of pneumococcal pneumonia. Very large amounts of purulent sputum with a foul odor may be associated with a disease called bronchiectasis, which we'll talk about later. Characteristics of sputum continued. Thick, tenacious, or sticky mucus may occur in patients with asthma or cystic fibrosis. If it's blood tinged, it may indicate a tumor or tuberculosis. Hemoptysis, blood tinged, bright red, frothy sputum, usually associated with a pulmonary edema. General manifestations of respiratory disease. Breathing patterns may be altered with respiratory disease. Normal rate 10 to 18 breaths per minute. Abnormalities that are seen are, the first one is something called Kussmaul respirations. Deep, rapid respirations, something like starving for air, found in acidosis or may follow strenuous exercise. It's seen a lot in diabetic ketoacidosis, which is a compensation mechanism to eliminate CO2 from the body to adjust pH and raise pH. Labored respirations are from obstructions of the airways, wheezing or whistling sound, obstructions of small passageways. Stridor, like a crowing noise, means an upper airway obstruction. Breath sounds may be abnormal or absent in respiratory disorders. Rales or rhonchi are abnormal sounds resulting from air mixing with excessive secretions in the lungs. Atelectasis means absence of sound. The word dyspnea means difficulty breathing. Cyanosis is a bluish coloring of skin due to large amounts of deoxygenated hemoglobin in the blood. Pleural pain results from inflammation or infection of the pleura. Friction rub, pleural membranes rubbing against each other. Changes in ABGs, causes of hypoxia. So we talked about this in A&P, and I referred to this as being like the little boats that are delivering the oxygen to the cells that are on the dock, okay? So when you have a decrease in red blood cells or hemoglobin, this is called anemic hypoxia, and you don't have enough red blood cells to deliver oxygen. And in the illustration, we didn't have enough boats to deliver the oxygen to the cells that were sitting on the dock. So this is anemic hypoxia. Circulatory impairment, this is called ischemic hypoxia. And so the water what the boats are on, they're stuck. They can't get anywhere because the circulation is impaired. Something that you see in congestive heart failure. Okay, circulation problem. The third one is impaired respiratory function. So this would be like hypoxemic hypoxia, inadequate ventilation, where the boats, or the red blood cells, do not have adequate oxygen. So something's wrong with the ventilation. You're not able to load up the cells with oxygen to deliver to the tissue cells. So this is hypoxemic hypoxia. Then the last one, like carbon monoxide poisoning or cyanide poisoning. In this case, that the hemoglobin binds the oxygen very tightly, doesn't release it. This is called histotoxic hypoxia. So you can't get any oxygen to the cells there either. And in some cases, like a cyanide poisoning, the cells are dead, so you can deliver all the oxygen you want to, and they're not going to be able to use it anyway. So those are 4 types of hypoxia. Again, the first one is anemic hypoxia. The second one is ischemic hypoxia. The third one, hypoxemic hypoxia. And the third one is a sort of histotoxic hypoxia if the cells are dead, but carbon monoxide poisoning is where you can't release the hemoglobin, oxygen from the hemoglobin. Okay. Infectious diseases, upper respiratory tract infections. The common cold is called infectious rhinitis. It's a viral infection, and the rhinovirus is the most common type of infectious agent. Adenovirus will also do it, parainfluenza virus, and coronavirus or other causative microbes for the rhinitis infection. What you'll see is mucous membranes of the nose and pharynx are red and swollen with increased secretions. You have nasal congestion and copious, meaning lots of watery discharge. Other symptoms, change of tone of voice, sore throat, headache, slight fever, and malaise, cough from nasal discharge. Treatment, acetaminophen for fever and aches, decongestants, which are vasoconstrictors to minimize mucus production. So they reduce the edema and congestion in respiratory passageways. Antihistamines reduce secretions but may cause excessive dryness and cough and may result in laryngitis if you take them over a period of time. Secondary bacterial infections, strep throat. Treated with proper antimicrobial drugs to reduce the risk of rheumatic fever or acute glomerulonephritis from alpha A beta hemolytic strep. Sinusitis is a bacterial infection, usually secondary to cold or allergy, obstructing drainage of paranasal sinuses into the nasal cavity, and that increased pressure causes pain and sometimes causes a sinus headache. Decongestants and analgesics are recommended along with antibiotics to eliminate infection. Laryngotracheobronchitis, that's a nice word, is also known as the croup. I had a problem with this when I was a little girl. Common viral infection in children, 1 to 2 years of age. Causative agents are the parainfluenza virus, adenovirus. Symptoms, inflammation of larynx and subglottic area cause characteristic barking cough, and it's a very painful cough. Epiglottitis, acute infection caused by H. influenza type B, children 3 to 7 years of age. And symptoms, supraglottic inflammation and swelling of the epiglottis, so it obstructs the airway. And these children are seen drooling, dysphagia, difficulty swallowing, high fever, rapid respiration and pulse, treatment, oxygen, and Antibiotic therapy is usually recommended in this type of problem. Influenza, flu, is a viral infection. Sudden onset, acute onset with fever, marked fatigue, and aching pains in the body may also cause pneumonia. The treatment is antiviral drugs like amantadine, acetaminophen, Relenza inhaler, acetaminophen, Tamiflu. Tamiflu is a really commonly used substance for these types of problems with the flu. Taken by adults on the first 2 days, reduces symptoms and duration. Vaccination is highly recommended of everyone. Lower respiratory tract infections, bronchiolitis, RSV infection, common infection in children 2 to 12 months of age, caused by respiratory syncytial virus RSV, which is a myxovirus. Symptoms: edema, wheezing, dyspnea, rapid shallow respirations, cough, rales, fever, malaise. Obstructions can cause atelectasis or non-aeration in lung tissue. Pneumonia may develop as a primary acute infection in the lungs or secondary to another infection, either respiratory or a systemic infection. Classification of pneumonias. The first one is lobar pneumonia, found in one or more lobes. Remember, with the lungs, you have 3 lobes on the right, 2 on the left. The cause usually is strep pneumonia. Sudden onset. The stages: the first is congestion, inflammation, and vascular congestion. And then if it persists over time, it can cause something called consolidation, which is an immune response that causes the formation. Stage 3 may result in pleural inflammation. Signs are high fever, chills, fatigue, leukocytosis, dyspnea, tachypnea. So dyspnea is difficulty breathing, tachypnea is rapid breathing, and tachycardia, rapid heart rate. Pleuritic pain, rales, cough with rusty colored sputum. Treatment: antibiotics, penicillin, fluids, and drugs to reduce fever. Bronchopneumonia is a diffuse pattern of infection in both lungs, caused by multiple strains of bacteria that thrive in pools of mucus. Symptoms: mild fever, cough, yellow-green sputum. And this is a picture showing you bronchopneumonia and patches of consolidation. The bottom left picture there shows you consolidation. And then lobar pneumonia, lower lobe is uniformly consolidated, and you can see it kind of looks like cement. And at the top, it's showing you diffuse bronchopneumonia, a diffuse condition there. Legionnaire's disease is a pneumonia that's caused by a gram-negative bacteria, and that is called Legionella pneumophila. It thrives in warm, moist environments such as air conditioning systems and spas. It's a nosocomial infection in hospitals and can be fatal if left untreated. Primary atypical pneumonia, PAP, causes scattered small patches of interstitial inflammation and is caused by Mycoplasma pneumoniae or an influenza virus. Symptoms: variable fever, headache, aching muscles, non-productive, hacking cough. E. Pneumocystis carinii pneumonia, PCP, is an influenza virus, also opportunistic, often fatal infection in patients with AIDS. It's a fungal infection. Tuberculosis. Cases are growing in number due to emerging multi-drug resistant strains caused by Mycobacterium tuberculosis, and a lot of the resistant strains are due to abuse of antibiotics and also contaminated needles. Inner cities seem to be where a lot of this is coming out of. But there are 2 stages to this infection. The primary infection is a local inflammation reaction, usually in the periphery of the upper lung lobe. Hypersensitivity response from infected lymph nodes causes a walling off of the infection by the immune cells. This is called a tubercle. Now, the secondary infection, if resistance decreases, organisms can become active and cause infection. And that's when cavitation occurs, destruction of lung tissue, and then you get erosion into the bronchi and blood vessels, swallowed bacteria infect the GI tract, pleurisy, inflammation of the pleural membranes, and adhesions may develop. The diagnostic test is the tubulin test, the Mantoux test, chest x-rays show active infection, and symptoms are malaise, fatigue, weight loss, low-grade fever, night sweats, cough, purulent sputum containing blood. Treatment: isoniazid, rifampin, and ethambutol. This is the development of tuberculosis. Here's the Mycobacterium tuberculosis infection. There's two ways this can go. If an individual has high resistance, then you get the tubercle formation. Calcination necrosis, that is where this is walled off by the immune system, and it looks on an x-ray like almost like something like cheese. It's white. It contains dead tissue cells and also macrophages, and is called a Gone complex when this is walled off. And then as time goes on and the person either becomes older, immunocompromised, resistance decreases later on in life, it can be reactivated, and then you go through the cavitation and the active infection and destruction of tissues and dissemination through lungs and other organs. If a person is susceptible immediately, an individual with low resistance automatically gets the infection, unable to fight it off, and you will test either way. With a positive tuberculin test will show there in both cases. Whether you have high resistance or not, you'll still test positive. And bacilli go to the lymph nodes and causes a delayed hypersensitivity response, and so you get this spreading into the lymph nodes. So that is the progression of tuberculosis. This picture is showing you on the left primary tuberculosis. Is showing you a Gone complex in lower part of the upper lobe. The top arrow shows the white-gray area. Lower arrow shows something near the hilus. So this is a hilar lymph node with caseation, and you can see how white that looks there. That's the area of necrosis. And B shows cavitation, what it looks like. Primary tuberculosis shows calcified lymph nodes. Healed tubercle with caseation necrosis, which is a Gone complex. And then spread of tuberculosis by way of the bronchial passageways. Histoplasmosis is a fungal infection common in the Midwestern United States. It's also called histoplasma encapsulation for the microbe that carries it. Can be inhaled with dust particles, and the course of the disease is similar to TB, but it's a different causative agent. And the treatment is amphotericin B. Fungizone is the common name for that medication. Cystic fibrosis is a common genetic disease. It comes from a defect in chromosome 7, which affects chloride ion transport in the cell membrane, and the secretions become very thick. You get this very thick mucus. The diagnostic tests: chloride sweat tests. You'll see the presence of fatty stools. You can do x-rays of the lungs, pulmonary function tests, and blood gas analysis to detect the disease. Treatment is a balanced diet, enzymes and salts. Sufficient fluid intake is important. Bronchodilators, humidifiers, and mild exercise help to eliminate secretions. This is the progression of cystic fibrosis. So it's an autosomal recessive disorder, chromosome 7. The exocrine gland dysfunction, it's a chloride transport dysfunction, and you wind up with excess sodium and chloride ion content from sweat glands. That's picked up in your sweat test that they can perform in the lab. But because of this chloride ion transport dysfunction, you have excessive amounts of thick, sticky mucus that obstructs the ducts of exocrine glands. So in the lungs, it obstructs the airways. You get frequent infections, and the cells surrounding it die. And when lung tissue is destroyed, it causes congestion in the lungs, which can result in cor pulmonale, which is a right-sided heart failure from the obstruction in the pulmonary circulation. Digestive tract, the meconium ileus, the intestinal obstruction of the newborn, results in obstruction of pancreatic ducts that causes fibrosis and leads to diabetes because you're not able to produce insulin. And then obstruction of the bile ducts of the liver causes biliary cirrhosis, and bile is needed to break down fats. The pancreas produces digestive enzymes as well as insulin and glucagon, so that affects absorption of nutrients. And then the reproductive tract, obstruction of the vas deferens blocks sperm flow, cervical mucus blocks sperm entry, and that results in infertility. And over time, the imbalances in sodium and chlorine cause electrolyte imbalances resulting in dehydration. So those are the multifaceted effects of cystic fibrosis depending on where it manifests itself. Lung cancer. This is obstructive lung diseases, and lung cancer. Bronchogenic carcinoma is the most common type of malignant lung tumor arising from the bronchial epithelium. Squamous cell carcinoma develops from the epithelial lining of a bronchus near the hilus. That's where the more the medial aspect of the lung, and projects into the airway. Adenocarcinoma from the glands, and bronchoalveolar cell carcinoma found in lung periphery, more diffuse. And when you get to small cell carcinoma, which is also called oat cell carcinoma, this is a very rapidly metastasizing, very diffuse type of cancer and moves very quickly. This picture is showing you bronchogenic carcinoma. The tumor here, which is a squamous cell carcinoma, appears gray-white, quite extensive on this picture, infiltrating the lung tissue. And in B, cytological examination of a sputum specimen shows squamous cell carcinoma, a cell with a very large nucleus, which is right by the arrow here. Effects of tumors on the lungs. Number one, obstruction. If the tumor is lodged in a bronchus, then it can affect airflow and getting air in and out of the lungs. Inflammation can cause a cough and possibly secondary infections. Pleural effusion, hemothorax and or pneumothorax due to inflammation or erosion of the pleural membrane. And then paraneoplastic syndrome by hormones that the tumor secretes, which may complicate diagnosis or treatment. And this is something that's very interesting because sometimes these tumor cells are able to produce hormones that act very similar to other hormones that are produced in the body. And one of them that's very common is ATCH, the one that affects the adrenal cortex. So that's paraneoplastic syndrome. Cause of lung cancer, the primary cause is cigarette smoking. That's the major factor in the development of lung cancer. Also, exposure to industrial carcinogens like silica, vinyl chloride, or asbestos is the other major cause. Signs and symptoms with many cancers, not just lung cancer, but many times the cancer is far progressed before it is diagnosed, unless it just happens to accidentally be diagnosed when other tests are being done for some other problem, but it metastasizes usually very quickly. Early signs of lung cancer related to respiratory involvement include persistent productive cough, dyspnea, and wheezing. If you happen to have a chest x-ray and detect it that way, hemoptysis, coughing up blood when tumor erodes tissue, so that's usually a later sign, and also chest pain. Pain is not usually an early sign of cancer. Hoarseness, edema in the face, headache, dysphagia, difficulty swallowing, or atelectasis. Systemic signs of lung cancer: weight loss, anemia, and fatigue. Paraneoplastic syndrome, indicated by the signs of an endocrine disorder related to specific hormones secreted when it's not really that endocrine problem. Signs of metastasis depend upon the site the cancer cells are displaced to. Diagnostic tests for detection of lung cancer: X-rays show lesions, atelectasis or pleural effusion. Bronchoscopy obtains secretions containing malignant cells. Biopsy, required for less accessible lesions. Pulmonary function tests check effect of tumor on airflow. So the treatment is surgical removal, chemotherapy, radiation. Prognosis is poor unless the tumor is in a very early stage of development. Aspiration involves the passage of food or fluid, vomitus, drugs, or other foreign material into the trachea and lungs. Emergency treatment: Heimlich maneuver to dislodge the solid object is recommended. A foreign object may be ejected from an infant by back blows administered between the infant's shoulder blades while the infant's body is supported over an arm or leg, head lower than the trunk. And this picture shows a granuloma in the lung resulting from aspiration of meat in a patient with MS. Asthma is a disease that involves periodic episodes of severe but reversible bronchial obstruction in persons with hypersensitive or hyperresponsive airways. There's two types. Extrinsic asthma is triggered by type 1 hypersensitivity reaction to an inhaled antigen. Intrinsic asthma, onset during adulthood, caused by respiratory infections, exposure to cold, exercise, aspirin, stress, and inhalation of irritants such as cigarette smoke. Pathology of acute asthma: all types of asthma exhibit the same changes during an acute attack: bronchoconstriction, inflammation of the mucosa with edema, and increased secretion of thick mucus in the passages. Interferes with airflow and oxygen supply. Pathophysiology of asthma: partial obstruction, hyperinflation within air sacs. Person is unable to exhale completely because small passageways leading to air sacs collapse. Total obstruction: mucus plug blocks the flow of air through the passageways, and this can lead to atelectasis or non-aeration of the tissue distal to the obstruction. Status asthmaticus: persistent severe attack of asthma that does not respond to therapy, often related to inadequate medical treatment. It may be fatal from severe hypoxia and acidosis resulting in cardiac arrhythmias or central nervous system depression. Causes of asthma: generally, there's a family history of hay fever. Asthma or eczema is common. Factors causing a significant rise in the number of asthma cases: increase in sedentary lifestyles. Children spend more time inside and are exposed to allergens in areas of poor ventilation. Increased air pollution, increase in obesity. Signs and symptoms of asthma: coughing, wheezing, mucus development, rapid heart rate, and hypoxia. Treatment: general treatment, skin test for allergens, avoid triggering factors, good ventilation is helpful, and mild aerobic exercise. Treatment for acute attacks: inhalers, dispensing a bronchodilator, albuterol, reducing anxiety and panic breathing exercises, corticosteroids, beclomethasone, beclovent prevents chronic inflammation. Prophylaxis and treatment of chronic asthma: leukotriene receptor antagonist. Those are Accolade and Singulair. They block the inflammatory response but not effective in the treatment of acute attacks. There's other things like antihistamines to block histamine receptors. Chromalin sodium inhalant that inhibits release of chemical mediators from mast cells, so it reduces histamines. Prophylactic med, helpful for athletes, but also helpful during an acute attack. COPD, chronic obstructive pulmonary disease. This is a group of common respiratory disorders characterized by progressive tissue degeneration and obstruction of airways in the lungs. There's three major types: emphysema, chronic bronchitis, and bronchiectasis. Emphysema causes destruction of alveolar walls and septae, which lead to large, permanently inflated alveolar air spaces, primarily caused by a deficiency in alpha-1 antitrypsin, which breaks down trypsin, which is an enzyme that breaks down a lot of proteins. So if you don't have the antitrypsin, then the trypsin can go rogue and mimic the symptoms characteristic of emphysema that's caused by cigarette smoking, which is your most common cause. Changes in lung tissue. Breakdown of alveolar walls, because remember, the alveoli are little clusters of grapes and there's a lot of surface area, but you're reducing the surface area and forming these large open pockets. Fibrosis and thickening of the bronchial walls, progressive difficulty with expiration due to collapse of the passageways coming into the little cluster of air sacs, and significant loss of lung tissue available for gas exchange over time, and the congestion and the tension leads to right-sided congestive heart failure. Signs and symptoms of emphysema. It's insidious onset, and it begins with dyspnea, difficulty breathing with exertion, and then progresses until it is evidenced even at rest. Hyperventilation maintains adequate oxygen levels until later stages. So you see people, one of the signs is being barrel-chested because you can get the air in, you can't get it out. Anorexia and fatigue contribute to weight loss. Diagnostic tests for emphysema. Chest x-rays, pulmonary function tests can detect changes in respiratory volumes. Treatment. Avoid respiratory irritants. Quit smoking, get some exercise, and maintain a good diet. Bronchodilators, antibiotics, oxygen therapy may be necessary as the condition advances. So here's a picture of what's going on with emphysema. A shows you normal alveolus. In emphysema, you can see how they're enlarged. C, you get air trapping. The air doesn't get out. And in D, you see normal lung alveoli. And then on the right, large spaces characteristic of emphysema. That's really a good picture. Kind of gives you a really good illustration there. Chronic bronchitis, another type of chronic obstructive pulmonary disease, results in significant changes in the bronchi, which are irreversible and progressive. Inflammation and obstructive repeated infections and chronic coughing characterize bronchitis as the following occur. Mucosa is inflamed and swollen. Hypertrophy and hyperplasia. Hypertrophy means enlargement. Hyperplasia means development of more cells, so the mucus glands undergo hyperplasia. Fibrosis and thickening of bronchial walls from chronic inflammation and irritation, and leads to increased obstruction, and stagnant mucus pools distal to obstruction are difficult to remove. And bacteria love to swim and play in stagnant pools of mucus, so very prone to more infection. When you think about the progression of these chronic obstructive pulmonary diseases, what happens initially is, because emphysema, aeration is sufficient, you get enlarged air spaces, but you can get the air in. They tend to be, in the early stages, they're called pink puffers because their coloration is pretty good. Cyanosis usually doesn't happen until later on in emphysema. Bronchitis is different because you don't get the air in, so they're referred to as blue bloaters because they tend to be cyanotic. Severe dyspnea, difficulty breathing, and fatigue interfere with daily activities. And then pulmonary hypertension and congestive heart failure are common. Causes of chronic bronchitis. Smoking, again, common cause, or living in an urban or industrial area where there is a lot of pollution. Signs and symptoms. Constant productive cough is the significant indicator. Right-sided congestive heart failure, systemic edema, cyanosis from obstructed airway. Treatment: reducing exposure to irritants, use of expectorants, bronchodilators, and appropriate chest therapy, including postural drainage and percussion to break up areas of mucus consolidation. Low flow oxygen and nutritional supplements are helpful. Bronchiectasis, our last one under chronic obstructive pulmonary diseases, usually a secondary problem, one that develops in patients with cystic fibrosis or COPD. Pathophysiology: an irreversible abnormal dilation or widening of medium-sized bronchi. Enlarged sacs accumulate mucus and bacteria thrive in these pools of mucus, so similar to what goes on in advanced emphysema and bronchitis. Signs and symptoms: chronic cough and copious amounts of purulent sputum, 1 to 2 cups per day, a lot of mucus production. Treatment: antibiotics, bronchodilators, and chest physiotherapy to break up mucus pockets. Now we go to restrictive lung diseases, and this applies to a group of diseases in which the lung expansion is impaired and total lung capacity, TLC, is reduced. Some pulmonary diseases may be classified in several categories because they have both obstructive and restrictive components. Two groups. First, you can have an abnormality in the chest wall that limits expansion. And remember, the word compliance means the ability of the lungs to expand. So we're going to refer to compliance, and you're going to see that pop up. Kyphosis, which is a hunchback. So if you're hunched over, you can't, compliance is reduced, you can't fill the lungs properly. Scoliosis, an abnormal curvature in the back. Amyotrophic lateral sclerosis, Lou Gehrig's disease, which can result in the paralysis of the muscles that control respiration. Same thing with poliomyelitis, botulism, or muscular dystrophy. So all involving the nervous connection to respiratory muscles. 2. Lung disease impairs expansion. Idiopathic, meaning that really is an unknown cause. Pulmonary fibrosis seems to have an immune basis, and adult respiratory distress syndrome. Pneumoconiosis, chronic restrictive diseases resulting from long-term exposure to irritating particles such as asbestos. So the pathophysiology here is healthy tissue is replaced by scar tissue, and then you have reduced compliance. You can't get enough air in because the scar tissue is not elastic like normal lung tissue is. Tissue changes caused are irreversible. Asbestos fibers can increase the risk of lung cancer. Well, the treatment here is pretty simple. End your exposure to whatever it is that's causing the problem, and it'll slow the progression of the disease and prompt treatment of the infection. Pulmonary edema. Now, these are vascular disorders. Fluid collecting in the alveoli and the interstitial area. Results from decreased oxygenation of the blood. Normal cause is pulmonary hypertension. Causes can result from many conditions, with left-sided congestive heart failure. Backup of the blood from the failing left ventricle causes high pressure in the pulmonary circulation. Also, hypoproteinemia and blocked lymphatic drainage in the lungs may cause edema with tumors or fibrosis. So this is a picture showing you a pulmonary edema associated with congestive heart failure. And as you can see here, the high hydrostatic pressure in the blood from the congestion, the blockage in the circulation, causes interstitial edema, so fluid seeps out. Fluid pressure increase causes fluid to go into the alveolus, and that reduces oxygen diffusion. And the fluid dilutes surfactant, which helps to decrease the surface tension inside the alveolus, and that results in alveoli collapse. And because of that, you have hypoxemia because you don't get the oxygen exchange, and so the blood's carrying less oxygen. Pulmonary embolus, a blood clot or other material that obstructs the pulmonary artery or branch of it, blocking blood flow through lung tissue. Most are thrombi or blood clots originating from the leg veins. Small or single embolus may be silent. Large emboli involving 60% or more of lung tissue can cause right-sided heart failure and decrease cardiac output. Signs and symptoms of pulmonary embolus are chest pain, cough, or dyspnea for small emboli. For larger emboli, chest pain, tachypnea, and dyspnea develop suddenly, and then later hemoptysis, coughing up blood, and fever are present. Massive emboli, severe crushing pain, decreased blood pressure, rapid weak pulse, and loss of consciousness, many times fatal. Diagnosis for pulmonary embolus can be confirmed with X-ray, lung scan, MRI, or pulmonary angiography. Treatment, underlying cause must be considered. In patients with pulmonary embolus due to a thrombus, administer oxygen and heparin or fibrinolytic agent to prevent additional clots, TPA, something like that. Mechanical ventilator may be necessary, and in some cases, embolectomy is performed to remove the embolus. So this picture here is showing you embolus from a leg vein coming up through the vena cava, and the passageways are fairly large from this point on into the right atrium, right ventricle. Then you get into the pulmonary circulation, and a single embolus may be silent, may not affect a large enough area. Multiple small emboli are equivalent to a large embolus blocking circulation. Moderate size embolus may cause respiratory distress and pulmonary infarction, and a very large embolus blocks all pulmonary circulation, leading to shock and cardiac arrest. Large embolus causes decreased blood returning in pulmonary vein and decreased cardiac output, and can result in circulatory failure. Atelectasis refers to a collapsed lung. If the lungs are not reinflated quickly, the lung tissue can become necrotic and infected, which can result in permanent lung damage. Signs and symptoms: small areas asymptomatic, large areas cause dyspnea, increased heart and respiratory rates, and chest pain. Causes of atelectasis: obstructive or resorptive atelectasis, total obstruction of airway due to mucus or a tumor. Compression atelectasis, when a mass or tumor exerts pressure on a lung and prevents air from entering that part of the body. Increased surface tension occurs with pulmonary edema or respiratory distress syndrome. The lung cannot expand. Contraction atelectasis, fibrotic tissue in the lungs or pleura may restrict expansion and lead to collapse. Postoperative atelectasis, 24 to 72 hours post-surgery, especially in abdominal surgery due to abdominal distension. Pleural effusion is the presence of excessive fluid in the pleural cavity. Excessive fluid can cause separation of the pleural membranes and cause atelectasis. Causes: exudative effusion, a response to inflammation, possibly from a tumor, in which increased capillary permeability allows fluid-containing protein and white blood cells to leak into the pleural cavity. Transudates, watery effusions, also called hydrothorax, either from increased hydrostatic pressure or decreased osmotic pressure in the blood. These effusions may occur secondary to liver or kidney disease, usually from kidney loss. Due to protein loss from failing kidneys, or the liver not being able to make proteins, and proteins are colloids that help to maintain blood volume in the circulation. Without those proteins, then fluid escapes, and this is where the effusion comes from. Pneumothorax, in this case, the fluid is blood. So this is showing you a picture of atelectasis and showing you a collapsed lung here, and you have pleural spaces filled with fluid, And there's a separation between the parietal pleura and the visceral pleura. Those are the two layers of the serous membrane. Here's compression atelectasis, an external mass pressing on the lungs causes atelectasis. And this is looking at atelectasis from an obstruction, and so it's a partial lung collapse. And this is showing you the airflow being obstructed, and the air just kind of escapes into the tissues and is not replaced. And so from non-aeration, that tissue collapses. Signs and symptoms of pleural effusion: dyspnea, chest pain, increased respiratory and heart rate. Pleurisy is manifested by cyclic pleuritic pain and a friction rub as rough swollen membranes move against each other during respiratory movements. Treatment is discover the underlying cause. Chest drainage tubes may be used to assist inflation. Thoracocentesis is needle aspiration to remove large quantities of fluid. Pneumothorax is where you have air in the pleural cavity. Can cause lung collapse. And so there are several types. Closed pneumothorax occurs when air can enter the pleural cavity through an opening directly from the airways. No opening in the chest wall, though. Simple or spontaneous pneumothorax occurs when a tear on the surface of the lung allows air to escape from the lung into the pleural cavity. As the lung collapses, the break is sealed, so the collapse is not complete. Secondary pneumothorax is associated with an underlying respiratory disease resulting from rupture of an emphysematoma bleb on the surface of the lung or erosion by tumor or a TB cavitation through visceral pleura. So you have these blebs that are formed from emphysema. They're little bubbles on the surface of the lung, and they break, and then air gets into the intrapleural space. Open pneumothorax, opening in the chest wall, trauma or surgery, results in atelectasis. Or somebody stabs you in the chest, right? Something like that. But it's an opening in the chest wall. Tension pneumothorax is the most serious form. Can arise from an open or closed pneumothorax. A flap is open and air flows into the pleural cavity. On expiration, the flap is closed and the air can't escape, so that results in atelectasis. Signs and symptoms: atelectasis, dyspnea, cough, and chest pain. Hypoxia develops and leads to a sympathetic response, including anxiety, tachycardia, and pallor. Interference with venous return leads to hypotension. And these are types of pneumothorax, maybe a little bit difficult to see. This is showing you spontaneous. A tear in the visceral pleura leads to air entering the pleural space from the lung and resulting in lung collapse. This is the normal lung here on the left with intrapleural pressure lower than intraalveolar pressure, and that's what keeps the lung inflated. Open pneumothorax, air enters the pleural space through an opening in the thorax and parietal pleura, resulting in atelectasis. And then here is tension pneumothorax, air enters the pleural space through the opening. And air cannot leave the pleural space here as the valve action seals the opening. So those are the different types of pneumothorax. Flail chest is something that results from fractures of the thorax. Usually 3 to 6 ribs broken in 2 places, or fracture of sternum and a number of consecutive ribs. During inspiration, there is a usual decrease in pressure inside the lungs, which makes the flail or broken section of the ribs move in from the decrease in pressure. Inward movement of the broken ribs prevents the expansion of the affected lung. A large flail section can compress adjacent lung tissue, and stale air from the affected lung crosses into the other lung. On expiration, the unstable flail is pushed out. Air from the unaffected lung moves into the affected lung. Can result in hypoxia from limited expansion and decreased inspiratory volume of the flail lung, the shunting of stale air between the lungs, which lowers the oxygen content of the air. So this is showing you a picture of what goes on with this large flail section. During inspiration, the low pressure inside the lungs pulls the flail section inward, compresses the lung on the affected side, also pushes the air over into the unaffected side, and then a large flail section causes air from the affected side to flow into the affected side, and on expiration, high pressure pushes the flail section outward. So it's a cycle which results in hypoxia over time. Infant Respiratory Distress Syndrome, IRDS, from a deficiency of surfactant, usually related to premature birth. It occurs more commonly in males and following cesarean delivery. Infants born to diabetic mothers are predisposed to this syndrome also. Signs and symptoms. Respiratory difficulty may be evident at birth or shortly thereafter, and by an increased respiratory rate greater than 60 breaths per minute. Diagnostic tests for IRDS. Arterial blood gas analysis monitors both oxygen and acid-base balance. Chest x-rays indicate areas of congestion and atelectasis. Synthetic surfactant. Gulfoscarol, Neosurf, neonatal, administered to the high-risk neonate both as a prophylaxis immediately following birth and as necessary therapy has greatly improved prognosis. Mechanical ventilation and oxygen therapy are required but carry risks. Adult Respiratory Distress Syndrome, ARDS, a restrictive disorder, but can be caused by systemic sepsis, prolonged shock, burns, aspiration, and smoke inhalation. Onset of respiratory distress usually occurs 1 to 2 days after the causative event. In many cases, it is associated with multiple organ dysfunction or failure secondary to a severe insult to the body. Signs and symptoms of ARDS: dyspnea, restlessness, rapid shallow respirations, and increased heart rate. Arterial blood gases will show significant decrease in oxygen. Treatment: oxygen therapy and mechanical ventilation until underlying cause is discovered. The prognosis is generally poor, however. Mortality rate is 30 to 40%, and with infection could be as high as 8 to 90%. And this is a little flow chart of adult respiratory distress syndrome. Alveolar pulmonary capillary wall injury, severe enough to cause cell damage, which causes decreased surfactant production. Increased capillary permeability, fluid and proteins leak into alveoli and interstitial tissue, which leads to pulmonary edema. And this results in reduced compliance. Can't get enough air in. Remember, we said compliance is the ability to get air into the lungs. And so breathing is labored. You'd have respiratory insufficiency because you're just not getting enough air in. And this decreased oxygenation results in hypoxemia. Decreased lung volume can lead to atelectasis and eventually cause respiratory failure. Some of the symptoms: confusion and decreased responsiveness, severe hypoxemia, progressive metabolic and respiratory acidosis, cardiac arrhythmias, and eventually shock. Acute respiratory failure, ARF, is the end result of many pulmonary disorders. It's indicated when the PCO2 is less than 50 millimeters of mercury, which is severe hypoxemia, or the PCO2 is greater than 50 millimeters of mercury. Remember, we know that CO2 levels are normally 35 to 45 millimeters of mercury, so that's called hypercapnia. And serum pH is less than 7.3. And remember, serum pH levels 7.35 to 7.45 normally, so that's quite low. Normal values: oxygen is 80 to 100 millimeters of mercury, and we already mentioned CO2 levels. Respiratory arrest refers to cessation of respiratory activity. ARF may result from acute or chronic disorders. Emphysema may lead to respiratory failure if the lung tissue degeneration progresses to a point where ventilation and gas exchange are minimal. A combination of a chronic with an acute disorder may lead to ARF. Example, ARF may develop earlier with emphysema if complicated by pneumonia or pneumothorax. Acute respiratory disorders like chest trauma, pulmonary embolus, or acute asthma may lead to failure. And many neuromuscular diseases, myasthenia gravis, ALS, muscular dystrophy, ultimately can result in ARF due to neurological complications. Signs and symptoms: labored respirations, general signs, hypoxia, hypercapnia, including headache, tachycardia, lethargy, and confusion. Primary problem must be resolved and supportive treatment given to maintain respiratory